I get thank you letters from families of patients that have died more than I get thank you letters of patients that have survived. You're embedded in their brain for the rest of their lives. It's an
Yes.
important time.
Incredibly vulnerable time too, right?
Hmm.
You're losing a loved one and you don't understand the system.
Yeah.
And we all know that we are all going to die, but we don't, what's the word that we use? We're in constant denial.
Hmm.
None of us acknowledge that we're getting older and that we're going to die someday because it would be just miserable to wake up in the morning.
Yep.
And now they're having to face that. And your words are everything that they're holding on to for many years. When we interviewed, Tony said that people can remember the glasses you're wearing, the color of your hair, the color of the shirt that you were wearing when you told them there's nothing else to do.
Hmm.
They can, such a vivid memory. They know every detail, like where they're sitting down, standing up, the color of the wall behind you. That's the beauty of medicine. You can make an impact by
Hmm.
just being a little nice.
And compassionate.
Yeah.
And that's medicine. That's bedside manner. That's not something that's, I guess it's taught, but it's learned over time. And I think that's being lost.
Mhm.
You have to have, I consider a physician, especially a physician like you, Jeff, like a Jedi master. You have to teach the Pod One learners. And those learners with these computers, you know how many backs of heads I see with doctors on the computer chopping away? They don't even talk to their patient. That's why Herb was talking about the AI scribes. I don't even type anymore.
Hmm.
I just let the thing work and I bring it to an office and I drop it in later. Yeah, I think that's much better. Now, insurance companies, I'm sure doesn't. Who pays for all this stuff, sir? It sounds like expensive stuff.
Well,
Hospitals or
the way we have it set up is the hospitals pay for our services, their equipment. So we can help guide them to which equipment works best, at least for us, and give them some recommendations. But the hospitals, they pay us a stipend for the shift. Again, we have the way my company works is we have it set up as number of patients based. So census, what's your daily census? So if you're, again, some hospitals, their daily census is 2. Okay, they're paying not much. Other hospitals, their daily census is 20. They're paying more. What we also do to offset that is that we assign our billing back to the hospital. So the hospital does the billing, our billing. So for critical care time, and it's really just critical care time that we're billing for the most part, they get to bill under our name and they get reimbursed for that amount of money.
sounds like concierge medicine, I guess.
You can look at it as fee for service. You're paying for our time. And then again, if you're just using a little bit of the time, you pay a little bit. If you're using most of our time, then you're paying more.
Interesting.
And how many patients, when you're on service, how many patients are you expected to be taken care of at once? Because you got patients all over the country. So,
Correct. So day shift, it's usually somewhere between 15 to 22 because we have to we're doing notes on all of these patients. And usually days are a little bit more hectic. Night shift, we can see a little bit more. We can see somewhere between 40 to maybe up to 50-ish. It depends. You get one sick patient, then there goes your whole night. But a lot of it is, okay, DKA, not a problem. Let's move on to the next one. This one's stable. This one's stable. So at night shift, and you don't have to do notes on all of the patients. Night shifts, we usually get an average of anywhere from 2 to 10 new patients a night. And we round on every patient. It's not like we're in a command center where we're overseeing 100, 150, 200 patients. We actually are going in and seeing every patient every night. So that kind of differentiates us from the bunker model or the more of the EICU type of model where there's a command center and you have a physician just sitting in a cubicle in an office building somewhere. Here, most of our physicians are at their home, but we can't see as many patients because we are actually seeing every patient. And when the nurses call for us, they get the physician. It's not a nurse, it's not a nurse practitioner or an APP. They get the physician.
Yeah.
and
So that helps with work-life balance. There must
I was going to ask you,
be, right?
before we move on. So what happens if you have 2 really critical care? Do you have a backup on call doctor that you could call because you're going to be tied up for 2 hours with someone?